Welcome. It's wonderful to see you again from lovely Poland. Unfortunately, we can't meet in person, but I would like to go back to the PrEP implementation issue in the CEE region and try to give you a little bit of information on the current context. I have also included COVID-19 information in the context of PrEP because we really don't know what will be happening. So we have a lot of issues related to that. So where are we now with the PrEP use worldwide? As you can see, the countries which have rolled out the PrEP are majorly South Africa, United States, Canada, Australia, and some Western European countries. So this rollout is expanding, and we could even say that it's more than 600,000 people on PrEP now, if we count from the second half of 2020. There will be probably much less data for the forthcoming months due to COVID, so nobody's really counting that, but this is where we stand. In Europe, the situation is slightly worse, but we have countries with better and worse initiations. Historically, of course, France is leading the floor, then Germany, United Kingdom, and the rollout throughout various countries is increasing. For example, Ukraine is now counted to have more than 1,100 initiations, which is like a very good landmark. There is also a lot of missing data on the people on PrEP. So if we look at the HIV and PrEP targets, we have 2020 targets, 2030 targets, and targets for Europe. So now we aim with HIV in general to reduce the HIV incidence by 2020 by 75% for the 2010 baseline, and to increase PrEP to 3 million. And I don't think this target is very well met. But also please note that PrEP is very tightly connected to discrimination, because PrEP access is actually related to the stigma, to the government and policies, and this is why I have included a small data about that. So we don't want any discrimination, we don't want any stigma, but this is strongly influencing our PrEP use and PrEP systems. So if we generally look at the PrEP systems, we have to think about certain principles. So we have needs-based access, so clinical appropriateness of PrEP. We need to expand the awareness in the populations, especially from the groups of high risk. We need to promote it positively both among possible users, HIV-infected people who might have partners who might be on PrEP, and also medical community, which is actually absolute key to success in the context of PrEP. More and more we see the tight endemics between HIV and STIs, and this is why PrEP has to be combined in the comprehensive package, standardized within clinical guidelines, and now a lot of countries have already developed PrEP guidelines and they are in use. Also, we need to support linkage to care in PrEP and monitor the system. So these are the key principles. Unfortunately, when we compare Western European countries to Central and Eastern European ones, you can see, and this is a very nice slide from the last year's Euro surveillance paper, where you can see on the left, I have divided it into the EU countries which have larger gap than EU mean, and on the right, smaller gap. So you can see that most of the Central and Eastern European countries have quite a wide gap compared to the Western European ones. The largest is for Russia. So this is also important. This is where we need to be heading to try to shorten this gap between people who declare that they need PrEP and actual PrEP users. And again, we can see very clearly that number of PrEP initiations is actually in a huge disproportion from the current epidemiology. So most of the Central and Eastern European countries have increasing epidemiology of HIV, increasing number of cases, and the uptake of PrEP is still very low there. If we would like to think about barriers to PrEP use, so these are key identified barriers. They have been identified last year. So one is the information gap. So we need to promote PrEP, we need to promote the demand, then make it as easy and as little medicalized as possible. We need to commit medical professionals, and we do this, and I think we are quite successful in that. Unfortunately, funding you will not get in the hostile political environment. So the stigma, discrimination, and political issues will be the key to successful implementation. So what I think are the key challenges: promoting knowledge, cost accessibility, availability across formal and informal platforms, access to prescription, and COVID. And this is why I have ordered this presentation, organized it the way I have. So what is happening now in the Central and Eastern Europe is a little bit of going backwards policy-wise. So for example, in Poland, LGBT rights issue now is very hot topic with a lot of protests, with some, and you can see this on the red on this slide, some of the communities have been passing anti-LGBT laws, which are actually discriminatory. Also, some protesters have been recently arrested. And if we could look at the LGBT rights index map, actually you can see that there is a gradient from left to right in Europe with discrimination and inequality index increases. So we can see it very clearly from this data. And also we can see that this gradient actually follows suit with formal PrEP availability. So in the dark green, you have countries where the formal PrEP, country-based PrEP are actually funded, and then there is a private prescriptions, and then you have no or poor formal implementation of PrEP. So this is the way it follows one with the other. Obviously, the cost now is less and less of the issue. Cost of prescription remains at the level of 20 to 30 euros per 30 pills, both online and on prescriptions. There are multiple generics of Tenofovir available across the countries. So there is a various also salts. All of them have proven similar efficacy in the context of PrEP, and both online and personal purchase is possible almost in every country. Obviously, this is Tenofovir desoproxil, so the first option which we had, and we know that Tenofovir desoproxil fumarate is actually a little bit more harmful than, for example, Tenofovir alafenamide. This is the data from the Discover study, where you have even slightly better efficacy in the context of prevention, and you have significantly better kidney and bone parameters. So this, will it be rolled out as PrEP in the Central and Eastern Europe? I don't think so. With a 30 to 20 euros cost of a generic PrEP, no governments will fund that, but this option will be open for the future. Also, we need to think about the data gaps. So I have shown you the example of two data gaps. We have very nice data on the small number of resistance mutations in people using PrEP worldwide. We do not have these data for Central and Eastern Europe, and we know that it may happen and it's linked to adherence. We also have very small data on the interconnectedness between chemsex use and PrEP. So we know that the chemsex is expanding also in Central and Eastern Europe, but we do not really know how it's linked to the use of PrEP within this context. So the last part of this presentation, a very brief one this year, I would like to go back to COVID-19 and PrEP and management in the disruption. So these are all difficult times for us. We know that there have been significant reductions in the testing access, both to STI, HIV, provision of protective equipment like condoms, provision of lubricant. The counseling access is slightly better, also because we switched to mobile and online counseling, and everybody is doing that. So this is both good and bad. There will be various online platforms where you can have a lot of support in the context of PrEP, and this will be developing. So I think a lot of PrEP consultation can be switched to online ones, especially when you have the results available. Obviously, we need to think that some of the NGOs who have had direct contacts with clients will stop working or will have limited acceptance of the new clients. And this is what we see in the context of COVID-19, but also within the CEE network, this context of control of COVID-19 pandemics and HIV services, we have to think about that. So the system is actually not working. Normally, 70% of the system is almost gone. Patients sometimes may be quarantined. PrEP people may be quarantined. Also, we do not know what is epidemiologically happening because we have much less contact. So this disruption is noticeable, and most of the clinics are not working normally because there is a link between infectious disease specialists and PrEP users. So this is again the point to promote PrEP for the primary healthcare physicians to have less ID resources used for PrEP in case of such epidemics. A little bit of comment on the PrEP agents and COVID-19. So we know that Tenofovir and remdesivir are slightly similar, and that in silico studies have shown that it can bind to SARS-CoV-2 polymerase, and that both tenofovir disoproxil and tenofovir alafenamide are inhibitors of DRP polymerase of SARS-2. So we know that, but the data are still uncertain. So this is a very large 4,000 patient trial for the prevention of SARS-CoV-2 using both hydroxychloroquine and tenofovir disoproxil emtricitabine with various arms. We know that first data of hydroxychloroquine show us that it doesn't work as prevention of COVID. So please note the statements on the PrEP use in the context of COVID. So there is a lot of data now, they are emerging, and we know that people should be retained on the usual card, and there is no data that HIV PrEP can protect you from COVID. So personal protection is the key, and it should be emphasized that our drugs may not work or are not working, or there is no data that they work against COVID-19. So to sum up, if we want to talk very briefly about successful barriers in the region, so we know that there are multiple grassroots initiatives, that there are multiple initiation studies which have been put a little bit on hold due to COVID-19. We have established network of committed specialists. We are expanding every year the awareness. Now there will be a boost online resources being used, and there is a vast array of tools which we can use, and the pharmacy access is better. On the other hand, the barriers are the stigma, STI risk, chemsex on adherence, state funding, which is the greatest hindrance, limited access to dedicated state-run clinics now, and poor or poorer access for people less than 18. Thank you. This was very brief today. I'm finishing with this quote, and hopefully you have enjoyed this presentation.